And so we will be starting in about 2 minutes, bang on the hour. I'd like to welcome everyone. Good morning, good day, good evening, wherever you are in the world listening into this webinar, and also listening in after if you've not been able to join us live. I'd like to warmly welcome all our panelists, whom I'll introduce later on before the panel session begins. We can have the next slide. Thank you. So today's presentation is on the role of pharmacists in closing the gender pain gap. My name is Parisa Aslani, and I'm a Vice President of FIP and also a Professor at the University of Sydney School of Pharmacy. Next slide, please. So the webinar today is being recorded and will be live streamed via YouTube. So you've got an opportunity to listen to it later. The recording will be available on our website, and you can see the website information here. You may ask questions using the question box provider, the Q&A box. Please feel free to write your question at any time during the session, and it'll be either answered during the session or separately as part of the panel session. You're also welcome to provide feedback to webinars at phip.org. And if you're not a member of FIP, please join us at that link over there. And like me, who's been a member for goodness knows about 30 years, you will reap the benefits of being an FIP member. Next slide, please. Today's program is for a duration of 1 hour. We'll start off with a 10-minute presentation on the introduction to gender pain gap, followed by another 10-minute presentation on the consequences and role of pharmacy in the gender pain gap. Then we'll have about a half-an-hour panel discussion before I hand over to our CEO, Dr. Catherine Duggan, to launch the FIP Gender Pain Gap report. And I'll finish off in a wrap-up towards the end. Next slide, please. So for today's session, the goals of today are to understand the gender inequalities in pain research, to increase your awareness of gender pain gap in treatment offers for pain management, for you to be able to describe the knowledge and training status and unconscious bias towards women in pain management, and define knowledge, attitudes, and practices that pharmacists have to close the gender pain gap. And finally, to be able to describe how pharmacists can support with, for example, training tools, etc., to address gender inequality in pain management and close the gender pain gap and better manage women's pain. Next slide, please. So without further ado, I'd like to introduce our first speaker, Dr. Jonathan Penham, who is currently the Secretary for the FIP Hospital Pharmacy Section and also a Senior Lecturer at the University of Sydney School of Pharmacy. Jonathan is an extremely experienced clinical pharmacist in the area of improving medication, specifically opioids in the hospital setting. His research uses both quantitative and qualitative methods to understand prescribing practices and develop strategies to improve medication use. Dr. Penham has published widely in the areas of medication safety and opioid stewardship and has over 100 publications. Dr. Penham's work has been cited by the Australian New Zealand College of Anaesthetists on how to optimise opioids to improve patient outcomes. So you'd agree that he is an expert in terms of pain management. He's chair of the Research Leadership Committee of the Society of Hospital Pharmacists of Australia and chair of the SHPA's New South Wales branch. So I'd like you to join me in welcoming Dr. John Penham as the next speaker. Thank you.
Thank you, Professor Aslani. It's a privilege to speak to you all today. I'll be just setting the scene around what is the gender pain gap, and I'll give you a few definitions. So there's going to be a few new terms, and then the speaker after me, Associate Professor Roger Naggs, will go into more detail on how we can put this into practice. So this will cover the key points I'll look at: what is the gender pain gap, key facts in research, then how it's reflected in some publications, and what some of the key takeaways using those definitions. So next slide, thank you. So what are we going to talk about tonight? Tonight's all about the gender pain gap. Obviously, pain is something that we all experience. It's universal, no matter what country you're in. But there is some literature showing that women may receive less intensive, effective, and lower quality treatment due to stereotypes attributed to women, such as dramatising, overemphasising their experiences in pain, having more willingness to report pain, not accurately reporting pain, or being less tolerant to pain compared to men. You know, this underestimation and undertreatment of women's pain worldwide is what's called the gender pain gap. So next slide. So the key words that I want you to know from this is also explicit bias and implicit bias. Now, some people have used this more regularly than others. Some people might be aware of this, particularly in the literature around gender differences, but also racial differences. So explicit bias, these are consciously held beliefs that are often expressed openly. And as you say, it's explicit bias. So it's direct bias against things. If people say things like, women overemphasize their pain, that's an explicit bias expressed openly, very directly. What happens a lot is not just explicit bias, and something that's more insidious and something more common is what we call implicit bias. These are usually attitudes or stereotypes that affect our understanding, actions, and a decision, often in an unconscious manner. But as the term suggests, implicit bias means it's bias that is implied. It's not said directly, it's not said openly, but it's often, with the terminology used or the looks or the glances, implies that you have some different ways of addressing pain because of some stereotypes that are held. And I'll go through some examples of this, but I think it's important to know there are two types of bias: the ones that are openly expressed, directly expressed, and then there's the implicit bias, the ones that are implied. I think that's really key because the implied ones are much harder for people to identify, and puts women in a very vulnerable position when they're not heard, when they've experienced those. So next slide. The other caveat that makes the pain gap even more difficult, or the gender pain gap more difficult, is that pain itself is difficult for us to measure. Look, we all know of the biopsychosocial model, that there are biological factors, there's psychological factors, and social factors that impact the types of pain that we experience. We all know that. Obviously, gender fits into the biological, but there's also psychological and social that we can't see. And so because we can't see it, it's very easy as healthcare professionals to make assumptions. You've all seen it in hospitals, in clinics. You say, "I'll just look at them, even though they say they're in pain, just look at how much they're talking, look at them on their phone, they can't be in pain." And it's really difficult then when you no longer trust what your patient is telling you. And there's some good articles that always talk about the patient's experience and the consumer experience of pain. And this is something that's commonly heard. It goes, if there is a single experience shared by virtually all chronic pain patients, it is that at some point those around them, chiefly practitioners like us, pharmacists, but also at times family members, come to question the authenticity of the patient's experience of pain. This response contributes powerfully to patients' dissatisfaction with the professional treatment system and to their search for alternatives. So already people with pain are being treated differently. People don't always believe them, they get questions, and their dissatisfaction with our system makes them go search elsewhere, often for inadequate or inappropriate treatment. And then when you have the gender attributes on top of that, that can make this an even worse experience. So next slide. So why are women impacted by this? So we know pain is universal, or we all experience it. We also know that nearly 80% of people with autoimmune diseases are women, and most of those autoimmune diseases come with a pain component. And so often many of these women are told that their pain and other symptoms are in their heads or labeled as chronic complainers, which is very unhelpful. Next slide. So there was a review around this implicit bias by healthcare professionals. It was done in 2018, and they found 77 studies looked at implicit bias in healthcare professionals around pain. And when I looked at the gender differences, it was coming out clearly that healthcare professionals often saw men as stoic when it came to pain. So when they complained about pain, it must be real pain. That was the assumption that they had. And there was this stereotype that when women talked about pain, they were being hysterical, emotional, complaining, or even fabricating their pain. And that stereotype impacted how we were treating them. Next slide. So you can see if we put in things like implicit bias and pain into PubMed, here we've got around 92 results. The review had around 77 papers. It's a relatively new concept. We don't have a large amount of research around this. We have a lack of research, I'll say, around that gender pain gap. And if I look at implicit bias, though, we have a lot more research around that, but it's really around racial disparities, that we treat different races differently based on the stereotypes of races. So a part of what I'm saying to you today, we've learned a lot from how we treat people of different races, and now we're also being able to apply that in this gender framework. Next slide. So again, within that review, they showed that people have different views of men and women when it came to pain. And then 12 studies also looked, did that actually impact the treatment we gave them? So we knew we interpreted their symptoms differently, but how did it affect treatment? There were some case studies where the patients, both male and female, presented to physicians and clinicians with exactly the same symptoms. So female patient, same symptom, male patient, same symptom. And they found the female patients often got less effective pain relief, less opioids, and they were often given more antidepressants and more health referrals. So you can see those stereotypes that we're talking about, when men were stoic and women were considered hysterical, it was impacting the treatment they were receiving. And that's a really tangential way of how people are being impacted by this, and inappropriate care is occurring and people aren't getting the pain relief that they're coming to healthcare professionals for. Next slide. So I've done some work in this space as well, and I want to use some student ones because I don't want to put any clinicians on the spot. But when we looked at students, this one was done looking at racial implicit bias, because that's where there was a lot more research. So we thought we'd start something simple and clear. And when we talk about implicit bias, we feel that there's around 3 main groups of people we'll come towards, and I suspect will be in our audience today. Look, some of you are aware of implicit bias and you go, you know what? We believe implicit bias, we know it affects our actions. We don't want it to, but it can. When we're busy, we go into autopilot. We understand that sometimes we make assumptions that aren't always correct. That's the first group. A second group is they believe in implicit bias, but they go, but I always pick up on it, I stop it, and it doesn't affect my actions. And I think, at the end of this webinar, it'd be great if we could all fall into that. If we're all aware of our implicit bias, all aware how we make assumptions about the people in front of us, and we stop that. We stop it from impacting our treatment. And we make sure we treat each of our patients as individuals and not by our stereotypes. But it is quite difficult to get to that stage. And lastly, we did find that there was a lot of people that even if you showed them the research, you do the tests, they don't really believe implicit bias is real. They go, really, this is just something we talk about. Either people have the biases, they don't, they know what they don't. I would never treat people without looking at them as an individual. And I think part of that is just being exposed to these type of literature and these discussions, and to hear consumer stories, to realize that some people have been very much hurt by our system, and we need to hear how we hurt them and how can we fix it. Next slide. This is some information coming from the Royal Pharmaceutical Society, which I thought was interesting. They have put out a document about how to address microaggressions in their workplace. Now, microaggression is another new term, and I'll explain it, but it falls underneath this implicit bias. It falls underneath implicit bias. So implicit bias was those biases we have that's kind of unconscious bias, unintended, and they come across, the action of those come across as microaggressions. So these are intentional or unintentional everyday comments or actions directed against a person who is usually part of a marginalized group that signal disrespect and inequality. And so it's great to see that pharmacy organizations have acknowledged microaggressions impact patient care. A microaggression can be when you don't intend to be biased, but you've just said something, and when everyone says it, it makes that person feel like they're not heard, they're not seen, they're not treated as a human being. It's when people go, she's overreacting, she's very emotional. If every single healthcare provider you encounter tells you you're overreacting, you're being emotional, it hurts. It hurts, and in some areas it's very common for people to say this. It's not deliberately trying to minimize the pain, but it comes across that way. It comes across that way. And I think we need to be aware that some of our everyday language has impacts on our patient, that language matters. Language matters. Next slide. So addressing it, I just want you to be aware of implicit bias, that it exists. Be aware of microaggressions, the words we use, the words we say, anything that can make people feel unheard, even if it's normal everyday speech. Be careful of it. It can really impact people's experience and the care that they receive. And we need to support healthcare professionals to provide equitable care that's more capable to meet the need of all patients, men and women. Next slide. Yeah, and so those are just the key points there that, pharmacists play a key role in pain management, and they should be aware of their gender stereotypes, which I know Associate Professor Nags will go into a bit more detail as well. So thank you for that. Yep, next slide.
Great. Thank you very much, Dr. John Penham. I'd like to take this opportunity to just remind you people on Zoom that if you have got questions for John or later on for other panelists, feel free to use the Q&A function at the bottom of the Zoom. So our next speaker is Professor Roger Nags, who's an associate professor at the University of Nottingham in the UK. Roger is a clinical academic pharmacist and provides both teaching and research within his role and maintains his regular clinical practice. His research interests are around analgesic medicines use and associated clinical outcomes, as well as healthcare utilization. He aims to promote the importance of pain within pharmacy and the role of pharmacy within pain management. Roger was the inaugural chair of the UK's Clinical Pharmacy Association Pain Management Group and is the current president-elect of the British Pain Society after having been vice president, honorary secretary, a co-opted and elected council member. In 2019, he was appointed a member of the Advisory Council on the Misuse of Drugs and is the chair of their technical committee. In addition, he has associations with several other healthcare policy and government organisations in the UK, including the Faculty of Pain Medicine, Care Quality Commission, and NICE. Please join me in welcoming Roger Fraz as our next speaker. Thank you.
Thank you for that introduction and also for the invitation to be part of this session today. It's very interesting to see the role that FIP plays on this very important and issue that has impact for many people. Next slide, please. I thought I would just begin by thinking a little bit about the gender differences in the prevalence, particularly of chronic pain. And so there are some chronic pain conditions that only occur in women. So obviously these largely relate to the reproductive system and include conditions such as endometriosis and menstrual pain. But then there are many other common types of chronic pain conditions that in which the prevalence is higher in women and females, and these include conditions such as fibromyalgia, but you can also see on the right-hand side of this slide conditions such as low back pain, osteoarthritis, migraine. So there is clearly a difference in terms of the prevalence of these conditions. And I think it's very important before we start thinking about treatment is that we actually recognise that these commons are more prevalent in women. Next slide, please. It's also worth thinking a little bit about the mechanisms that underlie these differences. And there's been quite a considerable amount of research looking at the hormonal changes and differences between men and women. And it's the effects on pain of the female sex hormones, estradiol and progesterone, are actually quite complex. And they have been shown in a range of different models to be either pain producing, so in other words, pro-nociceptive, or anti-nociceptive, in other words, providing relief from pain. Whereas testosterone, which worth remembering that women do have small amounts of testosterone as well, is predominantly anti-nociceptive. So in other words, pain relieving. And how is this presented? Well, we do know that low levels of testosterone are increased, associated with increased pain intensity, particularly prominent in men who take opioids at very high doses for long periods of time. And this causes a low serum testosterone. And hence, these people may actually present with increased pain. And also, low levels of testosterone have been associated with some of the anti-anabolic features of widespread pain conditions such as fibromyalgia. And another implication for the role of hormones is the changes in pain sensitivity during different parts of the menstrual cycle. And there are numerous studies that have demonstrated increased pain sensitivity during the luteal phase compared to the follicular phase, but also that other painful conditions are increased towards the end of the luteal phase as well. Next slide, please. But I think it's also become apparent that hormones are not the only contributing factor to this difference in the way in which men and women experience pain. And it's become increasingly apparent that the immune system, and particularly the microglia within the central nervous system, play a key role in the way in which genders feel and experience pain. And I know we're predominantly talking about things from a clinical perspective today, but in animal models, and it is metformin has been shown to reduce neuropathic pain by increasing microglial activation in male mice, but not in female mice. This has not been translated to humans, and there is a really big issue in terms of what has been shown to be effective in animal models into humans as well. But I think it does show that it is not solely an issue related to hormones, and I'm sure that over the next few years we will become increasingly aware of other contributors to this difference in pain. Next slide, please. So now let's think about some of the implications of this. Jonathan's already alluded to the fact that the doses that females and males need may be different, particularly in the case of opioids. Women actually need a higher dose to achieve the same therapeutic analgesic effect. There are also differences in the incidence of side effects. And it has been suggested that one of the reasons why women have reduced lower consumption of opioids in the post-op period is because they would prefer to avoid some of those very common side effects that we are very familiar with. Women are also more likely to have negative psychological effects with opioids. They are more likely than men to misuse prescription medicines, particularly opioids. And women who go on to develop an opioid use disorder are significantly more likely to begin with a prescription medicine as compared with men, where it is generally related to illicit opioids. Next slide, please. We've already heard a little bit about the different types of bias. This comes from a different study, but I just draw your attention to the points at the bottom of this slide. And it very much shows that our thoughts, behaviors have an impact on the choices of analgesics that we may choose. And as you can see in this study that came from the States, female practitioners being more likely to recommend non-opioid analgesics. And we also heard a little bit about ethnicity earlier on, that female practitioners being more likely to recommend non-opioids to Black people as compared to white people. Next slide, please. We've also seen the biopsychosocial model of pain, but I think it's also worth remembering that women, whilst they may experience more pain, are also more likely to have psychological comorbidities that influence the risk of developing chronic pain. These may be common psychological conditions such as depression and anxiety, but also adverse childhood experiences and particularly traumatic life events can have a big impact both on the pain that women experience, but also the treatments and analgesic use for chronic pain as well. Next slide, please. So I'm going to end with some potential opportunities that for the pharmacy profession. Obviously, this is not an issue for pharmacy alone, and it very much requires a collaborative approach with other healthcare professionals. As I have just shown, I think we need to have an awareness of the role of mental health and previous life experiences that and how they impact an individual perceives pain, but also on the management of pain. At the beginning of the presentation, I mentioned some common painful conditions that only occur in women, and I'm particularly thinking of menstrual pain. Here, very important to have a holistic approach, and whilst medicines may form a part of managing these symptoms, they are not the only recommendation that we can give to women that come into pharmacies. We can think about ensuring regular assessment and of both the effectiveness of prescribed analgesics and their tolerability as well. Next slide, please. Obviously, other issues relating to gender, particularly in pregnancy and breastfeeding, pharmacists are extremely well placed to be the source of information regarding use of medicines in pregnancy and breastfeeding. We can also think about research and evaluation of analgesic medicines, particularly in underrepresented groups. Might come as a surprise that particularly in the early stages of clinical development of new medicines, that most women are excluded from these studies because they are of childbearing age, and we don't necessarily know the pathogenicity of these medicines. And so it is important that in the later stages of development that there is an increasing understanding of the effects in these groups. And then finally, from a development perspective, thinking about targeting treatments specifically for different genders and at different times in the life course, particularly as we know that female sex hormones vary so much throughout their life. Thank you very much.
Great. Thank you very much, Roger. We'll now move on to our panel discussion. You've already heard a little bit from Roger and Jonathan. I'll introduce the other three panelists briefly. So Miranda Sertic is a licensed pharmacist. She's also an academic and associate professor at the University of Zagreb, Faculty of Pharmacy and Biochemistry. Her research focus is on the development of bioanalytical methods focused on breast cancer drugs and therapeutic drug monitoring. And she teaches on a range of graduate and postgraduate courses from pharmaceutical analysis, quality assurance, drug registration, all the way to pharmaceutical informatics, counterfeit medicines, and consultation skills. Our next panelist is Ms. Leticia Caligaris, and she's also a clinical pharmacist staff member at the University of the Republic of Uruguay. She specializes in analysis and monitoring of the Uruguayan pharmaceutical market. Currently, she's the professional secretary and has been involved in the implementing immunization service. Our next panelist is Dr. Jack Collins, who's a practicing community pharmacist and a postdoctoral researcher and an academic at the University of Sydney. His research interests include self-care, mental health, health policy, and health equity. Jack is also an executive committee member of the Social and Administrative Pharmacy section of FIP and was a recipient of the Young FIP Young Pharmacist Award for Professional Innovation. So we have our panelists here, and we're going to ask a few, or I'm going to ask a few questions from the panelist. So I'll pose a question, and if perhaps I'll start with Roger first, and then we might go to Leticia, Miranda, Jack, and John. This is just going around my screen. So the question is, if we focus on how pharmacists deliver pharmaceutical services, how do you see the gender pain gap affecting how pharmacists deliver their services, and specifically the relationship that they have with their patient? Roger, would you like to begin?
I think we have, or John and I didn't have any communication prior to our presentations, but it's interesting that bias, and particularly implicit bias, is something that we both consider to be extremely important. And I think that is perhaps the most important issue that we need to bear in mind, because it is going to impact on our the decisions that we make and the care that we provide to our patients. And so I think the first part of that is actually being aware of these differences in the first place. And then we need to be in a position to be able to think about how we can overcome these and ensure that we are not putting them or applying them perhaps the most important thing.
Great, thank you. Letitia, would you like to add to the responses provided?
Yes. First of all, I think that the pain is something that the patient feels, and I how to interpret what he's feeling. And I think that when someone came in the pharmacy with a broken arm, I know that he's suffering. But what happened is a patient say that I have a terrible headache. So I have to ask some questions, and that is the problem, because there are subjective things. So we have to understand, and we have to have tools, for example, to show the patients with faces or something like that, to know how much is the pain and how to say to the patient, and how to help him to talk with the doctors, because perhaps he don't go to the doctors. And another thing that, for example, if I have a bad day, my background are saying that all is bad, and I can't transmit that to the patient. So we have to be focused and don't have any personal do things in the pharmacy with the patients.
Great, thank you very much, Letitia. May I ask Miranda to comment? How do you think pharmacists, I guess their practice is affected by the gender pain gap?
Thank you, Parisa. Yes, well, we have heard in the opening lectures and now even in the panel discussion, I think it does affect the way we deliver the pharmaceutical care to our patients. And we have talked so much about bias, but I will also want to raise another question is, do we have sometimes enough time to talk to our patients, to gather enough information that we can recognize perhaps an underlying problem that's resulting in the pain? Do we have enough knowledge, information on different approaches, different programs that we can offer? Is our first and only choice to offer medication? Do we know when to refer the patient to a physician? And not just commenting from the pharmacist side, does our patient know how to describe their pain? Can we educate the patient? Can we help them in raising specific questions to help them describe their situation, their specific symptom, their specific pain, not just to us as pharmacists, but to other healthcare professionals as well?
Great, thank you. Jack, can I ask you to comment on this and tell us what you think is the impact of gender pain gap on delivering services?
Yep, thanks, Parisa. So I think we're all doing the right thing today by being here and starting this discussion, this discourse about the fact that the gender pain gap exists. So it's kind of a big, important first step to actually learn about it and educate ourselves. I think we can kind of leverage this knowledge that we have now to let's look at how is it negatively impacting our relationships, to how can we leverage that to improve our future relationships. So we've spoken a bit about acknowledging our biases. We know it exists. If we know it exists and we're perhaps the one healthcare professional in the chain that's the first person to reflect on the fact that the person in front of us could have been treated differently because of this gender pain gap, what can we do to make a difference? I think Miranda raised some fantastic things there. What are different ways that we can question even the language we use? I actually was reading earlier today in preparation for the webinar that when people write clinical notes about people's description of pain, clinicians will use words like hysterical to describe the pain that women experience. So can we think about the language that we as clinicians use ourselves, not only when communicating with patients, but also with other healthcare professionals as well?
Thank you very much, Jack. And finally, John, can you comment on this question, please?
Yeah, it's a good question. I think I look at it a collaborative team approach where I often have multiple people treating a patient. And when we acknowledge that we have our own biases, one of the parts of my talk was saying it's actually really, really hard to first identify it and stop it. Often we notice it after it happens. And it takes a while to change our behavior. We don't just change it overnight. And so one of the key ways to address this is actually having a diverse team. just acknowledging that we can't treat all people perfectly all the time. And we sometimes need different and diverse team members in our team looking after the patient who has their own strengths that supplement or complement our weaknesses. What that means is that when you're hiring and you're hiring more pharmacists in your pharmacy, other team members, it's often easy to hire people who are similar to yourself and who are like you. But what you end up doing is actually reinforcing these stereotypes and biases. And we often find in the literature that the more diverse teams, actually those who can treat a much wider variety of patients, more agile, more nimble, and can really help each other out.
Great, thank you. So there's a number of questions coming through the Q&A, and there's a stream at the moment, I guess a thread through some of those questions around what could pharmacists do in terms of, so we spoke about how the gender gap can affect delivery of services by pharmacists to patients. But if we think about what pharmacists can do in relation to other healthcare professionals and specifically prescribers, what is your advice towards our pharmacists out there in raising awareness or other ways of supporting other healthcare professionals to understand the gender pain gap? And perhaps I'll start also again with Roger and maybe go back to John on this and then come to Letitia, Miranda and Jack. Roger, is that okay?
Sorry, I was trying to answer one of the other questions in
sorry, you're on the Q&A. I know there's quite a number of questions there, but there's one specifically which kind of made me think about, well, what can pharmacists do to support other healthcare professionals such as physicians around the gender pain gap and therefore support patients and women?
Obviously, our expertise lies predominantly around drugs and medicines, and I only had time to very briefly touch on some of the differences in response to analgesics. So I think this is perhaps something that we need to be more aware of as professionals, and also the differences in dosing, if there are differences in dosing requirements between different genders as well, and so ensuring that the best evidence is being used in order to provide that care to patients.
Great, thank you very much. John, would you like to comment, please?
Yeah, I think it's a really difficult and sensitive topic. If you notice another healthcare professional, a physician, someone else in the team who might be treating a patient differently because of their gender, how you bring it up is extremely important and sensitive. Nobody wants to be accused of being a sexist. Nobody wants to be told that their treatment is inadequate and that they don't know what they're doing. And so the number one advice I'd say is that when you are giving this advice, what we should be doing as pharmacists is spending a fair bit of our time building relationships with our healthcare professionals. And just remember, we're on the same team. We're on the same team. We want the best outcome for our patients. We got to know our team members before we start having these deeper conversations. I feel like this is something you want to address. You want to be a patient advocate, but it will be heard much better if they know who you are, they know you understand them, and they also know that you've got the patient's best interest at heart. You're not trying to accuse them and make them look bad in front of the patient.
Great. Thank you very much, John. Letitia, would you like to comment on how pharmacists can support other healthcare professionals?
Yes, I think that we have in the pharmacy, we have a position with the patient that is very good to talk, because the patient came and can talk with us, and sometimes they cannot explain the pain. For example, the woman, sometimes they put a lot of emotional narrative thing that maybe instead of say the arms hurt me here, they say, well, that's pain, this makes me feel uncomfortable, lot of things. And we have to say, when you go to the doctor, get right to the point. Say the arm hurts here, so the doctor is going to understand the pain. The other thing I think that we have to say to them that they have to explain the pain experience and how affects the day. For example, the pain is from 2 a.m. to 4 a.m. and I get awake because of the pain. I think that we have to educate the patients on how to talk, and they have to know the different dose that they can take, and we have to be sometimes articulating the relationships between doctors and patient, but we have to try to they to understand, and we can do that.
Great, thank you very much. Miranda, what are your thoughts on how pharmacists can support other healthcare professionals to close this gender gap?
Thank you, Parisa. Well, as Jonathan already said, we do have to be very careful in the way we communicate this to our colleagues, to other healthcare professionals. And if this was a simple and straightforward answer, then we wouldn't be having this panel. We would already be doing it, right? So I would go back to raising awareness in ourselves first, us as a person, as an individual, then the pharmacy profession, and then work in parallel to develop our interprofessional collaboration in all fields, not just this issue. But I like what Letitia just said, you know, it's not just the communication towards the healthcare professional. We could do so much with educating the patient in how to pass the information and describe their problem as well.
Great, thank you very much. And finally, Jack, what comments do you have with regards to the support that pharmacists can provide?
Thanks, Bruce. I think this is highly dependent on your practice setting, and that's where it can be a little bit tricky. If you're working in a hospital and you're tightly integrated with other healthcare professionals, perhaps it's a little bit easier to have a lunchroom chat or in the corridor. I went to a very interesting webinar yesterday about this. It's a little bit trickier when you're working in pockets and silos in isolation from each other. So I think it's about taking opportune moments when they present or you stumble across them and seizing it to really educate other people in a polite way. And if it is about an individual situation with a particular patient, taking that person-centered approach. So always framing anything you're bringing up around the patient and your concerns about their best health outcomes or their safety, and less being critical or patronizing towards the other healthcare professionals. But it can be tricky, and I think it's just seizing whatever opportunities we're given to share information about this topic.
Thank you. So John gave a really good presentation around unconscious bias. So I'd like to pose to the panel to share with the audience a little bit about your own experiences around unconscious bias that you've seen pharmacy staff, pharmacists, or other healthcare professionals demonstrate towards women in the area of pain management. And I know that Jack's done a fair bit of work around this sort of area. So I might start with Jack and work my way back to Miranda and Letitia and finish off with John around this. And if the audience is wondering where Roger went, he had to go because he had another meeting. I didn't delete him off here, so he's just had to go. So Jack, can you tell us a little bit about the experiences, your experiences around unconscious bias towards women in pain management?
Absolutely. So the project that FIP funded for me when I won the innovation grant was actually to investigate implicit bias in community pharmacists using covert simulated patients here in Australia. And one of the cases actually happened to be dysmenorrhea. So there we go. We had a women's pain case. Whilst I was focusing on different races, what I found anecdotally when I was reviewing what had happened in those interactions was male pharmacists in particular were just quite uncomfortable addressing it, and they were kind of throwing mefenamic acid or NSAID that might be perceived to be better for dysmenorrhea, and that was kind of it. So I think there's also a little bit of a taboo topic in a certain aspect where, you know, take a non-steroidal anti-inflammatory, kind of go on your way. I saw that we had a question in the Q&A box about dysmenorrhea, specifically in absenteeism. I think that's quite interesting. That is as a university policy, very interesting. I think that's quite topical, and in women, it's these kinds of pains that I have seen it the most, to be honest, where it's kind of just you know, every woman experiences periods, you know, deal with it and move on. So it can be quite dismissive, I suppose. Yeah.
Thank you. Miranda, would you like to comment on your experience around unconscious bias?
Well, I'm sure that everybody has their own personal story where they experienced it, not just from a healthcare professional pharmacist, but also probably from family members and friends and colleagues at work. And even though I'm already aware of this thing, because we have been talking in FIP about the bias, not just to gender pain, but to pain in general, I would have to admit that I still do it. For example, to my kids, when they say I have a tummy ache, I'm like, is it just stress? Is it school, or is there a problem? So yeah, I just think we need to keep reminding ourselves to be open-minded, to listen what they're saying. And again, the person that we're talking to has to be well equipped on how to describe their pain. And then it will be easier for us to sympathize with them. So yeah, I'm sure that unfortunately we all do it, even when we are aware of the possibility that there is a bias towards it.
Thank you very much, Miranda. Letitia, could you share with us, I guess, your experiences around unconscious bias, whether it's pharmacy staff, pharmacists, or other healthcare professionals towards women in the area of pain management?
Yes, I think that, for example, in the pharmacy staff, we have men and women. Sometimes the women feels more comfortable to talk about menstrual pain with women than with a man. And sometimes you see that is the man going to attend her, they say, well, I get some pain in the back of my, and they don't feel free to talk with freedom, with some demands of what they are feeling. Women, for example, maybe understand better the women pain for menstrual, for example. And the other thing is religions, because sometimes we have some religions think that they can't take any medicines, and we have to know that. And the race of the color of the skin, sometimes we have to know that, for example, in Japan, for example, the people don't go to ask for pain relief to the pharmacy. We have to know that things. I think that it's very important to know who are your patients.
Great, thank you very much. John, final words around unconscious bias from you, please.
Yeah, I think Jack touched on a really good example around period pain, dysmenorrhea. I've seen people say how painful and how that's affected their life, and comments, people going, well, period pain is normal, and they're saying, and just basically just live with it. But, it's actually impacting their everyday life. And upon further examination, they've been come to emergency multiple times. And then they've done some more investigations, and then they've realized it's actually severe endometriosis, something much more severe. But it was that concept, that idea that period pain is normal, and it didn't matter what level of pain, even if it was affecting your everyday life, that's just normal. I think it's those types of thoughts that can be really damaging to some of our patients. We need to be thinking more deeply about that.
Great, thank you. So I have one last question to the panel, and really, I guess, reflecting on what we've heard today and the discussions, and also looking at the kind of questions that are coming through. What education do you think we need to provide, both at the university level and also to practicing pharmacists around this area, to upskill the future pharmacists and our current pharmacists? Maybe if I can start with Miranda, Letitia, John, and then Jack, if you let us know kind of what should we do, what education should we provide?
Thank you, Parisa. So being an academic and working in education of pharmacists, I do have to admit that we do not have a specific course dedicated to this topic. But I don't even think that we need a whole course. I just think that we need to raise awareness on this topic. And this can be implemented in courses like women's health or just general pharmaceutical care. But just start talking about it. Just talk to your students so that they are becoming aware that this topic is something that they grow with into becoming professionals. But I also think that we should not forget the pharmacist, the practicing pharmacist. So we need some sort of tool for continuous professional development or education, depending on the system in specific country, and just start doing like panels like this or topics, just start talking about it. But this is on the part of raising this as an issue, becoming aware of this gap that it exists about the bias that we all have. But specific tools that could help the pharmacist and also the patients in maybe how to approach a patient with pain problems, how we could teach them how to describe the pain, could also be very specific, useful tool that both pharmacists and patients can take with them.
Great, thank you very much. Letitia.
I think it's the same of Miranda, because we don't have in our education, we not cover this kind of things. So we have to raise our hand and say, hey, this we have to know more about the bias and to know the gap gender in the treatment of pain or in the treatment of anything. So I think that we have to raise our hands and to say, hey, we have to talk about this.
Right, thank you. John.
Yeah, I agree with the comments already stated. One thing that we've done at our school that's been quite good from an education point of view is to have consumers come into the classroom, to make sure students are hearing the story of a consumer, to remembering that the aim of pharmacy school is not to be a genius and know all your medicines. The aim is to treat the patients in front of us, to provide care for our patients, the patients at the center. And I think we really need to hear those stories often. You know, there's a bit of distrust that's occurred now with healthcare professionals. They say, we know better. How you can't tell us, we've gone to pharmacy school, we know it all, and patients feeling like their concerns aren't heard. And, you know, often patients will say, yes, but you spent 1 or 2 hours on this topic. I've spent the last 20 years learning about this topic. So I think we really need to keep our focus on the patients, hear their stories, and reflect on how our role has impacted that journey.
Right. And finally, Jack.
I agree with all the other panelists 100%. I think this is a relatively new area. Our understanding is only just the tip of the iceberg, I think. So even as a panelist here today, I'm going to have to continue to educate myself on this topic as it grows and we learn more about it over time. So just like anything else in therapeutics, as practitioners, as educators, as policymakers, we need to make sure that we're up to date.
Excellent. Thank you very much, panelists. I'm now going to hand over to our CEO, Dr. Catherine Duggan, who will give us a few words around the Insight Board. Over to you, Catherine.
Thanks so much, Parisa, for your superb chairmanship of this panel today and of the previous speakers. And thank you so much to the panel and speakers for what we've heard. So we undertook an Insight Board to inform our thinking around this. And I just wanted to walk you through where we've got to with that as we launch the report today. A few acknowledgements, Parisa again, then some of our colleagues from the team at FIP, Nilhan, Lena, Oscar, Alison, Noor and Isu. Isu is with us today on the call. And also from our experts, some of whom have taken part today as well. Miranda, we had Satina, Dalal, Jack, Kenji, Jonathan, Yaya, Huang, Letitia, and also just a big thanks for unrestricted funds for this work from Reckitt Benckiser. Now, I wanted to just walk you through the format of this kind of report because it's pretty new to FIP. We want to be able to produce perhaps reports that are more qualitative or more issue focused to spark some future work. So for this report, we undertook a literature review briefly. We then held an Insight Board with the expertise that I showcased. The Insight Board is run very much like a focus group, so we should regard the report's findings as a snapshot or as a qualitative or descriptive summary. We got the responses there and we collated it into the report that we launched today. And one of the things that we want to do with the reports from such Insight Boards is to spark the issue. hence the event today, to really think about what it is that we want to take forward next, perhaps the portfolio of work that might be part of our work on pain, and with the focus on the gender pain gap that we've discussed today. So the key findings from the report won't surprise you because they have been very much illustrated during today. Pharmacists can be supported to address the gender pain gap through education and partnerships and CPD. And I must say, Parisa, through events like today, self-awareness and training about gender pain gap or differences between the genders are issues not only owned by pharmacists. Of course, we're not the only ones who support patients and the public with their pain care, but we play a distinctive and important role. It's really important, as you heard Jack summarise right at the end of that last question, to expand our individual knowledge to all gaps in pain management, not just the gender pain gap. I think understanding how we all respond to pain, maybe even the normalisation that both Jonathan and Jack mentioned around symptoms like dysmenorrhea, but you can expand that to people who suffer with migraine long-term or who suffer with arthritis. Normalization of pain really can become quite dangerous because then we don't look for worsening or any kind of underlying symptoms. Small steps to close the gender pain gap: education on bias, unconscious, perhaps subjective views. That's really, really important, that affect the services we give on pain management, full stop. We could even work to create protocols for pharmacists and their teams, providing tools to measure and evaluate pharmacists and interventions. These are necessary probably to approach and solve the problem. So the next slide would be the ability for all of you to download the report, which is here. Scan the QR code that's on the screen. It's available in our FIP library. And as I say, it provides us with a qualitative and descriptive summary of where next. And we'll be working with colleagues on this call, this panel today. Colleagues, the Q's and A's that you've given, which will give us an idea of the information you'd like to see from FIP, but also ways in which we could respond easily, quickly, and draw together some of the expertise. Next slide, please. A quick summary then from me, from what I've heard. Pain itself is subjective. Jonathan gave us the big picture right at the very start. We've got the implicit bias. We have to challenge ourselves with this, as well as to think about how we might observe biases within our teams. All the factors that he walked us through, psychosocial assumptions, and all of these, if we don't address them and just follow our bias, they lead to a reduced trust. I really enjoyed Roger's walk through the physiology, the pharmacology, the hormonal differences. Even the fact that mefenamic acid, very often prescribed for dysmenorrhea, works better in men is a very intriguing concept. The entire issue of equity here and trials and the impact is a huge ethical dilemma that we should, at FIP, pull together, maybe an insight board on one of those. Then the fabulous panel, all of your insights were really interesting to me. How we measure pain, how we try to get people to describe their pain very clearly, very objectively, so that the person in front of them can treat the problem rather than the feeling. It's really interesting as well to me when I was listening to the panel that our profession is predominantly female. And just because we have females in the profession, there are still biases there. The light bulb moment for me was normalization of pain. And today in the news in the UK, there is an initiative being proposed that over-the-counter or purchases of OTCs in many different retail sectors could provide some insight into underlying conditions, pain being part of that. For example, buying symptomatic relief for bloating may lead to uncovering unseen ovarian cancers, for example. So this whole idea about the iceberg of pain relief is one that we should take very importantly, and one that we should be supporting our profession. The idea that we've got pressures on our shoulders around time, being able to create the space for a clear, objective conversation with a colleague. We need to build trust with our healthcare professionals and with patients themselves, and time and trust are really fundamental in that. The sector itself may also be impactful. where you're part of the multidisciplinary team and you can have those incidental conversations, that's often much more easy, whereas much more effort has to be made if you are a sole practitioner. But the issue here for me is the fact that normalization of any pain in any patient can prove detrimental. The gender pain gap emphasizes and exacerbates that, and it's something we should all be mindful of. And then we need to create the tools and the environments for everybody to be able to manage that better. I think that's enough in conclusion from me. I see we've gone over time a little bit, so I'm very delighted, Parisa, to hand back to you for some final remarks as we close the session. Wonderful panel to have together today and a great build on the Insight report. I look forward to more work in this area. Thank you, Parisa.
Thank you, Catherine. And I'd like to close in just 30 seconds to thank our panelists, Jack Collins, Jonathan Penham, Miranda Sertic, Letitia Caligaris, and Roger Nags, who had to leave early, and our CEO, Catherine, for a beautiful sum up of the session. I don't think I can add to that other than just my own reflections of there are underlying hormonal and biochemical mechanisms that are responsible. There is also the implicit and explicit biases around how we treat people with pain, as well as women with pain. And I think that there is quite a great opportunity for both within the undergraduate system as well as the postgraduate system for pharmacists to raise awareness around bias, around gender bias, around racial bias, around the unconscious bias in treatment for pain, for chronic pain, and great opportunities to educate not only around the underlying, I guess, hormonal and biochemical mechanisms, but that biopsychosocial issues that also impact our bias and how we treat our patients. So I hope that as the audience, you have got a hell of a lot of information and opportunities to act on that within your own regions and countries. There are a lot of questions in the Q&A, and I believe that we will attempt to address those as part of the ongoing next stages into this insight. So please again, join me quietly in your own area to clap hands and thank our panel and our speakers. Thank you. And thank you all of you for joining us. See you next time.